permission or no?
Yes, I've given you permission. You can record, mate.
All your intellectual property we're about to steal from you.
This is how most of the podcast starts. So everybody, this is how we do the vet vault interviews is on Zoom, just not normally with 50 people in the room, obviously. And it's, you'd think after 2 years we'd have it a little bit smoother, where it's not like, oh, who's recording? Are you? Oh, sit. Yes, that's recording. We're seasoned professionals. Everybody, let's do introduction. So if you don't know me, I'm Hubert Himstra, one of the hosts of the Vet Vault podcast. If you haven't listened to the Vet Vault, why not? Gerardo, you all know Gerardo, Dr. Gerardo.
Hey, Dame.
I don't know, how do you introduce you? I don't think we have to introduce.
Who's the more famous of you two?
Hubert.
And then we have Dr. Steve Joslyn. Steve, you might not know yet. Steve is a veterinarian, firstly. Secondly, a veterinary radiologist, so specialist, an imagician, as I like to call them.
Imaginer.
An imaginer.
Yeah, diagnostic imagining.
I really like that. That makes it sound magical and kind of.
It was actually a typo on my co-resident's badge. It just had diagnostic imaginer, and she was like, "Actually, I prefer that. That's way better."
And then more recently, Steve's also a tech founder of a tech company, which you should keep your ears and eyes open for. It is coming for the clinic near you. VetDB. I'll find it. I'll put the link in the chat at some point. It's a vet data management system, which is astounding. It's going to blow your socks off when you see it. Starts with paperless vaccination records linked with blockchain technology. I don't quite understand it. Steve is clearly
no. There's a simpler way to explain it. We just lock medical data to the animal's microchip now. Yeah. So the existing microchip, wherever it goes, that's the key for the data.
So our goal for tonight, this was Steve's idea. Steve kindly joined us on the Vet Vault Clinical. If you haven't come across the Vet Vault Clinical, it's a subscriber podcast where we do 20, 30-minute little podcasts that educate, where we want to teach you one or two new things. I learn from it every time with specialists from different fields. And Dr. Steve joined us to do a couple of episodes on radiology, on how to interpret radiology, which you think wouldn't work on a podcast, but it worked really well. I learned so much from it. And Steve said, hey, why don't we do a live session? Why don't we look at some pictures instead of just talking about them on a podcast? And I'll go through some images. And the goal is not specifically to, well, in my mind, we'll see how this transpires, but we don't want to just say, look, this is a picture of X. Remember what that picture looks like for when we see it. What I'd love to get from this personally is to see how Steve's mind works. Not all of his mind, because some of his mind you don't want to dig into. It's a strange mind. But but at least when it comes to radiology, how does he look at them? How does he work through it systematically? And of course, we're going to look at some cool x-rays and look at some interesting cases. Thank you for a couple of people who have sent some images. Gerardo sent a few through. I'm going to steal the first one, though. I sent Steve a picture already that I want.
I haven't got the links to the other ones, though. Is that still?
Yeah, it's I will try and I just got a few on Instagram. I'm still figuring out how to get them down. So
well, if you just send me the links, then I should be able to at least down.
They're not links. The actual photos on Instagram. Is that going to be any good for you?
Like a photo of the screen.
Yep.
That's my favorite.
Yeah, we'll see. So we'll work with what you've got. I'll see if I can figure out a way to get it bigger.
Oh, it's a photo of the screen from far away with the blurred image.
They're good. They're actually good photos, mate.
There's in Glasgow, the guys were getting so frustrated because people were sending them photos of x-rays or photos of a screen, and they said, we just got to make this a study. And they looked at it just like giving those images to radiologists. And turns out they weren't that bad. They could still see everything they needed to, so they couldn't complain about it anymore.
Well, I told you that the reason I wanted to get Steve on the podcast to talk about specifically abdominal radiology, I've become really lazy with abdo rads. When I get a case in, I can do it in a right ultrasound. So when I have an acute abdomen case, I'm straight to the ultrasound. I generally just
same with me. I'll go ultrasound for X-ray.
Tend to skip X-rays, and then over beers one day, me and Steve had this discussion about which he prefers. And he says, no, there's nothing or very few things that he can't pick on an X-ray that I can pick on an ultrasound. I was like, bullshit.
That's a trained
You
set
can't.
of eyeballs there.
And then I thought I was a clever dick one night. I was at work and I had an X-lab, a foreign body, but it wasn't it's quite a tricky one to picture. And we actually did do X-rays first. And I looked at the X-rays. I was like, there's no ways I could tell on this that it was a surgical case. I did it, and then I scanned it, and I was like, yeah, it was like a sock or some soft tissue structure. And I thought, let me test Steve. So I did that, took a photo of the screen with my iPhone, sent him the picture at 10 o'clock at night at home and said, what's to go with this case, mate? Smarty pants. And like a second later, he writes back and says, cut.
Like, yeah, it actually came up on my my Apple Watch. I could see it on that. I was like, yeah, you better cut that.
Okay, so it is a 3-year-old bulldog cross, and you want to know male bulldog cross, and do you want to know signs, what it came in for?
I'm guessing coughing or some sort of respiratory.
Okay, I'll just give you the full history.
Was it vomiting? Did it come in for vomiting?
Well, chronic history of vomiting, but what made it come into the emergency clinic was coughing and respiratory distress. So to me, that there is respiratory distress. It was an easy enough diagnosis, but Steve, work through it.
Yeah, sure. Okay. So I've got the 3 views in front of me. So both left lateral, right lateral, and a dorsal ventral view. Obviously, we think this is dorsal ventral view because there's a lot of gas in the fundus still here. But I will check that really quickly. So the whole dorsal ventral versus ventral dorsal, there's a lot of little extra bits that will kind of pop up to help you work through a case. So knowing that this is dorsal ventral versus ventral dorsal is a little bit helpful. The one problem though is that there's a lot of gas in this pyloric region of the stomach as well. So it's not as confusing or not as clear. But then looking at the shape of the diaphragm as well. So we don't really have that Mickey Mouse appearance just yet. I think those lungs are kind of heading up all the way there. But then the last check that we can do, in fact, this is a very confusing setup because I actually want to make this a ventral dorsal. But anyways, the spine itself. So I'm just going to do a bit of a draw just to explain this. 2 people, you want to let those people in the waiting room there, here? Can you see that? Yep. Right. So just it's popping up on my screen, so I'm just going to admit them. So dorsal ventral, obviously the X-ray beam would be up above here, and it just kind of heads out like a little triangle like this. And obviously, if you imagine that that's the beam coming down, so the beam should highlight the disc perfectly because it passes straight through those discs right here. So the back of the thoracic spine should be really well highlighted with end plates, and the front of the thoracic spine should be hard to see. But if we see here, the front thoracic spine, they're a little bit overlapped. And as we get to the back, so I actually believe this is a DV view. And again, that's a lot of effort just to say DV versus VD, but sometimes that is quite relevant, especially if things aren't labeled. So let's dive in a little bit here. So the first thing I see on this left lateral view is that there's, yeah, sorry.
Why do you care about VD/DV? I think I know, but just clarify, why do I care which it is?
So, I mean, I guess the perfect example here is that you see how the left lateral view and the right lateral view here, very starkly different lung opacity down here, right? And it's a little bit more blended here. Caring whether or not this is a left lateral versus right lateral will tell me that all that should be on the right side of the lung. And the same sort of thought process goes on the VD versus VD. If you can see something really well, like in South Africa, you get those spirosuchar lupi granulomas in the esophagus. If you see them really well highlighted on that DV view, then you can kind of help work out where that is. It helps you bring some differentials to the table. But if all you did was a VD view, you'd miss those lesions almost entirely. So it's just really knowing what you have and what it's really good at showing.
So in lungs, the surface that is closest to you away from the table, that's going to be what's highlighted. Am I right?
A little bit, yeah, with the aerated lung nice and high, yeah. So I think based on what we have here is a DV view, a right lateral and a left lateral. Very quickly, I'm going to double click on this so everyone can see. I'm going to do a quick pass to the skeletal structures first, just so I can kind of delete them from my mental capacity, or what did Ella call it the other day? The mental mental load. I had a lot of mental load by not picking up my shoes at the door. So in any case, removing all of these skeletal structures. I mentioned very quickly, when you're going through the spine, grab things in threes. So in this case, C7, C6, C5, C4, C3. I'm going to look at that vertebral body, C3, at the same time as 4, at the same time as 5, and then 4, 5, and 6. And I'm assessing the spinous processes. I'm looking at the facet joints, the canal itself, and the intervertebral frame. And so I'm grabbing in 3. In fact, I might just draw a line. I'm grabbing in 3, I'm grabbing in 3, all the way down, sort of thing. And then once I get through here, you see how your mind is not even being cluttered with what's going on in the chest. It takes a little bit more time, but you just want to make sure you're not going to miss anything. So once I'm happy with the spine, they'll do the same with the ribs. So I'm going to grab pairs of ribs in 3s, and then grab each one of those and move down as well. If you do find that ribs are a little bit hard to see, just try to rotate it, and all of a sudden the ribs become really obvious. So ribs are now going left to right across our screen. That's the way our eyes are, and now the ribs are much more obvious than everything else. The other thing you can do is invert it too, but I don't have the shortcut on my computer to invert it. That just emphasizes the ribs a lot more. So after I'm done the ribs, the sternobray, the costochondral junction, and then the spine too. So scapula, scapular spine, glenohumeral joint, humerus, just making sure there's nothing popping out and nothing needs our attention. I did that quickly on the right lateral view as well. Again, ignoring the super obvious stuff in the abdomen and the thorax, just making sure that we can delete skeletal issues from our concern. And then the last thing as well, the same thing on the DV view. There's a little bit of mineralization up here. So does anybody pop their hands up if they know what that is? Just put a little zoom button just around there. Gerardo here, you know what those are?
I'm going to decline from my answer.
I do know what they are, but I don't want to tell anyone. So yeah.
Somebody put it in the chat. Okay. and if you're okay, I'll confess.
I
I don't know what it is. I don't know what it is.
I have no idea actually. Skeletal.
Yeah.
If you say something in the chat and you're wrong, nobody cares. Just have a go. Put something in there, please.
But the reason why this is relevant is sometimes people will think this is a sort of a mineralization of the biceps muscle tendon. Or they might see it on another view superimposed over the trachea, and then they're going, ooh, there's a tracheal foreign body in that coughing dog sort of thing. So I can't see the chat, but I assume somebody might have said something.
Somebody said microchip?
No, microchip. So it's a little bit more mineralized. Sorry, it's a bit more mineralized rather than metallic. It doesn't stand up as sharp as like this little guy.
I was going to guess the bicep tendonite, the sort of mineralization of the biceps tendon. Nah, not it?
Not quite. It's a little bit. I'm just going to see if we can see it on the other side here. Sometimes we see it down here. I think it might be there, but it has the look of the, it's a bit high for that biceps and a bit wide. It has the looks of a clavicle, or just a clavicle remnant, or just that little mineralization where the clavicle is. So in the cat, you'd obviously see it coming across from the shoulders there. All right, so skeletal structures all deleted here. Now, before I dive into the thoracic cavity itself, I'm going to have a quick look at that abdomen, and obviously you've sent an abdomen view as well, so I can bring that across here as well. So the first thing that we do, again, skeletal structures, nothing jumping out, os penis, who cares, right? So the first thing I'm going to look at in the abdomen is just general temperament of the abdomen. So making sure the serosal detail, we can see really nice margins to the liver down here. The splenic tail is really nicely highlighted. We have nice margins around the urinary bladder, around the kidneys as well. And we're starting to lose a lot of detail up here, even though there's this large aerated tubular structures, we just can't really see. I'm just going to zoom in a little bit. Can't really see that sort of detail. Where's the back of the stomach? Instead, we have really aerated pylorus, and we have a lot of gas in the duodenum coming across the screen here. And then we have a little bit of residual gas in the fundus as well. One of the things that's remarkable about just that view there is that normally the fundus is far bigger than the pylorus. So something is not right with the way that this pylorus is maintaining its big size here. So that's just one thing to note. It is a left lateral view, I think. Yeah, left lateral view. So all the gas should be going to the pylorus and then feeding out through the duodenum. But in any case, right now, I'm not too much worried about the gas in this duodenum because looking at the size of that, doesn't really measure up to 765. It's a little bit big, actually. Okay, so the diameter of the duodenum is a little bit big. There's just going to bring that back to this view here. See if we can come down. Why is he so big? Fundus looks relatively unremarkable with that rugal fold. Pylorus just looks like he's like almost like it's forming a little bit of a rounded. They call this the tit sign. Back in the days when they had just radiology, they had really funny names for things. But anyways, it looks like a teat, and it's not meant to be any feminine body part. It's more from the dairy world, but a tit sign. But in any case, it just looks a bit more rounded than you see for a pylorus. So something's not quite right at that pyloric region, and potentially just a reason for giving that size of that duodenum just coming across here. So let's bring the lungs back. All right, but in any case, if we're going to now dive into the thorax, I'll come back to my thoughts on the abdomen after a bit of the thorax. First thing I'm going to do after I've done the thoracic boundaries is just look at the pleural space. So on all three views, make sure the lung is heading all the way out to the margins, as we can see here, and then heading down. So we have lung aerated heading all the way up to where it should be. So I'm happy with that left side of the lung. Let me delete all those. Now I'm going to do the right side of the lung. There's a little bit of a separate, it's a bit rotated. So you have one lung that's hitting that part, one lung that hits that part. So that's just a bit of rotation. But the lungs are heading up to that line, which is kind of made up from the inside of the ribs. So we know that the lung is fully aerated on these views. But looks like we just have a little bit more definition of lung down here. And of course, this generalized increased opacity in this ventral field as well. So, but anyways, I'm not going to talk about lung. I'm just talking about the pleural space. And then if we load up the dorsal ventral view, tell me if I'm going too fast and if it's not blurry. If this is good, thumbs up. Yeah, happy. Okay. Are you getting a bunch of people that are dropping off? No. Right, so lung is heading all the way up to the boundaries on the left side, as we saw in the lateral view. So we're pretty happy here. Hugs the crura of the diaphragm, hugs the mediastinum. Left lung is pretty much unremarkable. So at this stage, I'm probably not going to care anymore with the left lung. It just looks great. But overall, there's just this massive increase in opacity in this region here. So the first thing I'm going to write down, there's increased lung opacity in the right cranial, right middle lung region. And going back to that pleural margins, you see now we're starting to get some separation of the lung away from that boundary. So that lung should be coming all the way up to there. But there's separation. And we even see some lobar sign coming here, a little bit of separation there. And then we got to say, oh, cool. If the lung is being separated from that pleural wall, from that thoracic boundary, what opacity is left in that space? So what opacity is that? Well, there's only a couple of things it can be. So it can't be soft tissue, just because we would probably get effacement with this border of lung here anyways. So it's going to be less dense than soft tissue. So it's either fat or fluid. And just the fact that I see how there's I'm just going to re-window this a little bit, but there's just this continuous opacity that heads all the way out to the thoracic musculature. So I think this is soft tissue opacity or fluid opacity rather than fat. Right, so now we have lung lobe retraction. It looks like it's the ventral aspect of the right caudal, right middle, and then right cranial, plus all this increased opacity. Right, so now we load up that left lateral view. And the one thing that's really strikingly beautiful is this air bronchogram. So really, well, actually, I might just draw with my pen if I can. Pencil, no, brush. So we have this air bronchogram that comes down here, and it's highlighted by all of this dense lung. So the air bronchogram really is just this tree in fog sort of visual appearance. And what it means is that the lung is now soft tissue and is completely effacing the pulmonary vein, which should be central, and the artery. It's completely effacing. We can't see those pulmonary veins at all. So this is now an alveolar lung pattern, and it's giving us the air bronchogram. And the fact that this lung is actually the airway comes back. Oop. Get rid of that. Give my pencil. Brush is a B. Cool. So we have the trachea comes down and it drops straight down in. So this is the right middle lung lobe, and the right cranial comes by this way. And if you look at that right cranial lung lobe, we have the same thing. We have this air bronchogram filling up this space here, and lots of dense. Oh, of course I had to do that. Oh, cool. And lots of dense, come on, stop, lung surrounding it, and we don't see the vessels either side. So we have two alveolar lung patterns causing air bronchogram, and it's involving the ventral aspect of the right cranial and the ventral aspect of the right middle. But everything else looks pretty normal lung opacity. Okay. The next question I'm going to have is just how are those airways looking? Are they looking normal?
Good question.
Yep.
So can you show me an area in the lung where you do see normal vasculature? Just so we can compare.
Sure.
Maybe of the view.
Yeah, the other view is nice, wasn't it? Yeah, this is great. Okay, so just going to zoom in for everybody. And of course, I got the nice skills to make that more obvious. But if we have the airway running down the middle, we've got a pulmonary artery above and a pulmonary vein below. Veins are central and ventral.
How do you explain, Steve? How do you explain the normal lung pattern there? I don't know. I have students go, well, "How do you know it's normal?" And it's like it looks like a wispy spider web. Like I don't know. It just looks clear. You know, like you got fine little blood vessels going through it, which reach out to the peripheries. You know, I don't know. It looks like I don't know. How would you explain that?
Yeah, I guess it's always a common thing. Like I think people see vascular markings and go, "Oh, there's a vascular pattern," or they see airways, like this guy here, this beautiful endon bronchus. That's a nice thin airway either side. So he's not even that alarming. There's a couple of big airways here, and just because they get big, we start going, "Ooh, is there a bronchial pattern here too?" Yeah, I guess that's probably practice, and then seeing lots of them. But just the fact that all of these vessels, like this network of vessel here, I'm just going to make that a little bit more obvious for everyone. Coming down here, that's getting smaller and smaller as you head to the periphery, and it seems to be hugging and following the airways themselves. So I'm just, by definition, there's nothing really wrong with that vascular marking. If that was getting tortuous, or if it was different sizes to the other ones next to it, then you could start to say that. But yeah, to be honest, Gerard, what you say there in terms of students and vets going, is there a vascular, is there a bronchial pattern? It's a lot of times because they can see it and they think, "Ooh, I can see that. Therefore, is that abnormal?" So practice, and then just like honing in and seeing what is this that I'm looking at, like this little soft tissue tubular structure heading out and getting nice and small as we head to the periphery. Again, nothing abnormal about that. If that's a soft tissue tubular structure, it has to be a vessel and it's doing what it should. Perhaps maybe, still trying to answer that question, Gerard, but perhaps maybe some people take it all in at the same time in terms of the whole appearance of the whole thing and the busyness, and they go, "Oh, you know what, there's a lot going on. I'm going to say bronchial, I'm going to say vascular," whereas probably just focusing in on the few things that you can identify to make that just a normal vascular pattern.
Yeah, sure.
Right.
So thanks. Sorry, I distracted you.
Yep. All right. So far what we have ventrally collecting alveolar lung pattern in the right cranial and the right middle lung lobes. The other lung lobes are mostly unaffected, but the extra thing that is making this problematic is this retraction of the lung lobe. So with that fluid opacity, so we have alveolar lung pattern, right middle, right cranial with what I think is pleural effusion. And so then, to complicate matters, we have a very large pylorus and a large duodenum. So from all of that, to link it all up, so your primary differential is going to be the one that explains everything, and everything fits together. In this case here, I'll probably put it to the chat. What do we think is the, on face value, what's the most likely reason for that alveolar lung pattern just affecting that right middle and right cranial lung lobe, ignoring the pleural effusion? That's a little bit of a complicated. I don't know if, is there chats going on? Chats, yes. Aspiration pneumonia, perfect. Okay. All right, so lots of aspiration pneumonia, and that's exactly what we happen if you have that regurgitation or aspirating of that vomitus. It's going to come and it's going to collect on the dependent aspect, and it's going to drop into the first airways that it can. And so obviously it's going to drop into the that right cranial, and it's going to drop really nicely into that right middle. But all these airways remain unaffected. Even the accessory is pretty much boring. So aspiration pneumonia for sure, and the fact that we have some pyloric or gastric emptying abnormality up here, that would explain it. What I can't explain on that is the pleural effusion. So there's a few options there. Chronic aspiration pneumonia, when you do have just untreated or perpetual pneumonia going on, you can start to get to that pleuritis level, and then you're starting to ooze into that region. That's one possibility.
Was it, as I understand, it was a fairly acute onset. Again, the chronic vomiter. But how? Because that's, I was just wondering, could you get leakage of fluid around that inflamed lung?
Yeah, you definitely will get leakage. It's just a lot longer than compared to those pleural pneumonias you see in production animals, where like pneumonia is the first sign that you really see before they start coughing. But yeah, I would suspect that it would have to be, there's either something else going on, which just seems pretty unlikely or unlucky, or that pneumonia has been going on to the point where it's starting to cause some pleuritis, and maybe it's even up high, like maybe it's happening up here, and all that sort of inflammation and reaction is just now trickling down. The one thing about that, I mean, that to me looks like it's got to be fluid. It's not a fat dog.
Yeah, so you said earlier fat. If you say fat in the pleural space, is that just obesity?
Oh, obesity, yeah. So, I mean, right now we have really nice margins to the heart below. So there's no effacement. They're just starting to, maybe just down in this region here, there's just a little bit more opacity that makes it hard to see the ventral aspect of the heart and the cranial aspect of the diaphragm. But I don't see, there's a little bit of a fluid line down here. So yeah, I think it's still this pleural effusion. It's just really hard to pair pleural effusion with an aspiration pneumonia unless there was some rigorous coughing and we're getting some pleuritis with it. It's really stretching my brain a little bit to pair those up. But then let's just finish by going back into that abdomen, see if we can see anything. You didn't have the other couple of views.
No, sorry, man. It wasn't actually my case. I just looked at it, and then it came in as a lung case, but with a history of being a bit of a vomiter.
Yeah, I mean, this gas, if that's patent, this gas should pass all through. Like, it should not be like ballooning up in this pyloric region while the fundus is just sitting there kind of lazy. So it's definitely an interesting one. Even if it was like had this weird torsion where it was twisting on its axis and the pipe, but managed to stay in the same spot, so not really a GDV, still that should all go out the duodenum, and we should have gas going there.
So you wouldn't look at that and go, it's just aerophagia because you've got a lung dog and you're panting and coughing. You're happy to say no, there's an issue that needs. Unfortunately, I don't know the long-term outcome of this. Longer term, typical emergency, we thought at night for the respiratory issue, dealt with that, and then said, all right.
No, the pylorus shouldn't really be bigger than the fundus. The fundus, you know how wide the fundus gets and how small the pylorus, that muscular component, is trying to squeeze everything down. If it's under that sort of pressure, then the fundus just takes it. It's passive, so it just shouldn't be that big. I think there's some sort of pyloric antrum issue there. What was this? You said this was a bulldog?
Yeah, bulldog
No.
cross. It was listed as a bulldog, but he wasn't a normal flat-faced English bulldog.
And how old?
I was about. This doesn't look like a bulldog test.
No, it's not a typical bulldog.
Young one?
Youngish, yeah. I think 3, if I recall.
Because I think there's that stenosis that bulldogs can get, pyloric stenosis, and so it's a congenital, or at least a not a developmental, a congenital issue, but perhaps. I've got a few questions here. So main issue probably is the stomach, since aspiration pneumonia is caused. Yeah, that's Tina's just said that main issue is likely stomach or duodenum here. And then the aspiration pneumonia is a very quick one to explain the lung changes. The pleural changes make it a little bit more complicated. And
that's pretty hectic sign on that.
Oh yeah, this one. Yeah. So really strong lobar sign there, and that just shows us the right caudal lung lobe, which is the only one being shown in this view here. This is the right caudal lung lobe, is really nicely contrasting with that right middle, and you can even see. Actually, I'm just going to zoom in. Sorry, you can even see that airway. Try to do the
air bronchogram there.
Yeah, air bronchogram beautifully there. So it's amazing. It's like far more obvious on the abdominal view than everything else, but that's a nice one.
Would that be because the angle of where the beam's slicing the lobes?
Yeah, yeah, I'd say that's probably the best explanation for it. Let's just bring them both up at the same time. Let's go kill this guy and bring right middle. And then... Yeah, so it is a little bit more blended. It almost looks like it starts there, but the point of maximum lobar sign is kind of there. Or is that heart? We've got a bit of heart overlap. It's just a little bit more blurry, kind of in between there and there. Yeah, I think that's probably the best explanation for that, Gerardo. I think you're right.
That is the best explanation of a chest X-ray that I've ever heard.
Oh, I definitely. So the one thing is, like, obviously, it's become habit going through a chest X-ray or an abdominal X-ray that I forget to kind of explain some of the steps that I kind of passed over really quickly. So like, I didn't really care about the bladder. Bladder's in the normal spot, normal position. It's got a little bit of a bump from the little intestines there, but there's no big mass in that region to explain why this bladder goes like that. So I just think everything's getting pushed back by the pylorus. And that's pushing the intestines back, and the intestines are like, hey, can I just nestle in here into that little bladder spot there? And the bladder's like, yeah, I don't care. I'm not that full. So bladder, I didn't care about. Large intestine, descending colon, I didn't really care about. Kidneys have really nice margins. I can't see, I have trouble seeing the margins up here. I think that might be the cranial margin. But even if there was a little bit of an indent there, I'm not even going to talk about it because it's probably just a loop of intestine that's passing on top of that. But the main thing is that right kidney is there, left kidney is there. They're roughly the right shape, size, location, and that's pretty much all I'm going to pull out of it. If we want a lot more detail about the kidney, that's when we do the ultrasound. Yeah. So.
A couple of quick ones, Steve, on that image you've got there, the lateral of the chest. So we wanted to make sure that there wasn't any megaesophagus. Is that little bit? Nobody can see my pointer.
Yep, no, you're right. There's a little bit of gas.
A little bit of gas above there. Is that a concern?
And a little bit down here as well. And you got some superimposed at the same time. So again, if we only have one shot, just load it up with the other view as well. And just see if it's still there. Even though it's the left ladder, we should still see that gas in the esophagus. See a little bit of fluid kind of here. This is where the esophagus comes across, and you can look for a little bit of residual fluid there. But in other case, I just don't see the gas there. So the fact that it's not there in the second one just means there was probably transient. It might be abnormal, but it's just gone by the second time. So we just can't make it an abnormal finding.
Okay, cool.
And then... yeah, I'll just quickly go through. So it's very hard to see the aorta, but it's coming up past here. And vena cava is just coming through here. And then everything else in the craniomediastinum, you just can't even talk about. So there's lots of fat in the craniomediastinum, wrapping the brachiocephalic trunk, craniovena cava, thymus in a young dog. There's just no detail. It's all squashed in there that we just can't see. All we can really tell in terms of craniomediastinum is width, So find the inside of the lungs and a little bit there. So we still have a little bit of aerated lung that shows it there. And provided that is 2 times the width, actually, I'll just do a little measurement tool. Provided the width of the spine is not more than 2 times the medius, not less than half the mediastinum, the mediastinum is fine. So there's a lot of still big question marks that you maybe, like with ultrasound, maybe you guys get such good answers and you can see it and you can take it. You can almost ask, how is it feeling, sort of thing. With radiography, we can only really comment on what we can see, and we kind of can't make assumptions on things that we can't see. So, but in this case here, pleural effusion with aspiration pneumonia, secondary to whatever's going on in that pyloric region. Now you might even say ultrasound can come to the table.
Yeah. And I really, really love that. I'm going to make a few comments, and I would love people to ask questions. Really, this is my goal with this, is that people engage in this. And again, there's no dumb questions. I've been doing this for 20 years. I still have questions. If I've learned one thing, it's just ask it. Somebody else is thinking it.
I had a question. I was seeing a GP clinic recently, and they were doing the just the basic spay, the 3-clamp technique. And the one thing I could never work out in my mind is, like, if you tie the suture through those 2 clamps, which are spreading it out and making it very tight, as soon as you tighten that suture, it's just going to rip through that tissue. And this vet's like, yeah, we figured that a long time ago. And it's like, basically, you crush it a little bit, you make it go down, and then you tighten it across. I don't know. It just seemed like something that, it was a very stupid question I felt on my part. It's like, how do you do that? But I'm hoping that means that other people here can ask whatever question they want. There really isn't a stupid question.
While people type big questions or think about big questions, a couple of comments. The first thing, and I'm going to quote Steve from when we did the podcast, and with a big paradigm shift for me in reading radiology, but also just approaching my cases in general, is Steve says that when you start looking at your x-rays, check your brain in at the door and just describe what you're seeing. So I don't know about the rest of you guys, but I look at an x-ray and I immediately think diagnosis.
Yes.
What's wrong with this? And I go blind to 90% of the thing on the image. All these little cool things that Steve's pointing out, I don't even look at it because I'm just thinking of differentials. Steve's description of check your brain in at the door. First, just describe what you see. Now, I'm starting to do that, Steve, ever since you've said that. With when I'm writing my histories, I'm actually just focusing, instead of just jumping to conclusions, going, okay, what have I got on my clinical examination? What have I got on my blood test? And it's the typical SOAP approach. That's how we're taught to do it, but most of us chuck that out the door because we want to be quick and efficient. But I love that approach. And the other reason I chose this case specifically is because on that one lateral view, you cannot even see that lung. Yeah, that horrendously clearly munted lung. On the single view, if you're just doing one view lateral, one view DV, well, the DV will give it to you, but still, how easy is it to miss that major pathology by just taking a single view? And I, hands up, I confess, up until fairly recently, I did one view lateral, one view DV, and that was my, unless I was looking for new plays series or something like that. So I think that's really fantastic. Thanks, Steve, for that one.
Yeah, it actually, but you be like, left lung field good, right lung field munted. Is that your radiology interpretation of this X-ray?
Well, because like you're using your eyes.
Right, we're not allowed to make fun of people.
I'm making fun of you. You make fun of me all the time.
So I'm just going to load up an image, and just pre-warning, don't even write it down in the chat, but just have a think of what it is that you're seeing. I just don't want anybody to see the answer. And if you know it, obviously keep it to yourself. This is a really good thing for how you use your eyes without your brain. And your eyes will work something out before your brain does, which is kind of seems intuitive. The eyes are kind of part of the brain. But anyways, work with me on that. I'm just going to load it up. You can't see anything, I don't think. Yes, you can't see anything. Okay. So this is an ink blot. I'm just going to make it nice and big. Can you guys see that? Okay. So the cool thing about this image is that your eyes naturally want to go to a certain spot, and your eyes are like, whoa, something's not right there. And this goes back to the days when we were either predator or prey. I'd say maybe we have a lot of anxiety, so I think we were prey before we were predators. But anyways, our eyes are going, there's something there, and I don't know what it is yet, but my eyes are drawn to it. And what your eyes are already doing are probably marking out some margins that your brain hasn't quite worked out what it is yet. So do we have a hands poll? Can we do that? Like a little hand, like a little, isn't there like a little thumbs up thing in this thing?
Yeah. What do you mean?
Like, if someone to like volunteer what they think they see?
Reactions.
Okay.
Yeah.
Like
Let's go. Yeah. So Tina, or actually Taryn. Taryn,
Madison's got.
Where did you see that? Just anybody want to unmute yourself? Tell me what you see there.
Don't want to pick somebody.
I can't even see the. Can I do that?
I've got the list. I'm going to scroll through and ask somebody if they want to.
What, Shauna?
Actually, still can't see anything.
I'm going to unmute you, Shauna. Can you see? Oh no, can I unmute?
Yeah, I can. Let me try it.
Okay, there, unmuted. All right, what do you see there, Shauna?
I'm struggling to see anything. My eyes are kind of drawn to the top left, which is
over here.
No. Yeah.
Yep.
But am I supposed to be at the middle? I don't know.
It's right. So about a third and maybe to a quarter of people will be drawn up here, and we think those are the more the predatorial type personalities, and the prey type personalities are usually drawn into the middle here.
I saw something in the middle, like a wolf's head in the middle.
Some people I've heard say an old lady's face or a pig's tail or something like that. Does anybody know with 100% certainty of what they're looking at here?
Joy said in the chat. Dog sniffing a tree.
Yeah, that's good. Okay, so
I think Linda can see what I can see.
Right. So what we got here, I'm just going to draw, is we've got the short little tail and his back, and then his neck, and this is his collar. This is his floppy ear, and this is his snout on the ground. Comes back up. This is his left fore coming down.
Oh, I got you now.
And then his left hind is kind of sitting down here, and obviously he's a castrated male or a female dog. Right hind coming up here, little butt and little tail, and obviously the other end. So that's the Dalmatian sniffing the ground, and up here is probably a base of a tree. Exactly right. But the cool thing is that most people will be drawn to either this area here or that area, and that's our eyes, and that's the skill that we want to get when it comes to the radiographs. We want to be able to let our eyes do that pattern recognition and sort of edge detection and all that sort of stuff without our brain going, what is it? You got 5 minutes to figure this out, and then the owner's going to be pissed off at you, and then the boss is not going to all that sort of stuff.
This picture is a great lesson in looking at the entire picture, because if you look at the entire picture, it says mysterious Dalmatian optical illusion.
No. It was sitting there the whole time.
When it comes to X-rays, I always find that it's helpful to like stand back about
and see the whole
3 meters back, 3 meters back, and then you look at it and you're like, and I get a much better understanding of an image 3 meters back from the screen, than 30 centimeters.
That's that happens quite a bit. Like you'll notice in some of the radiology reading rooms, they're sitting back and they're scooching the chair all the way back. I had that one unfortunate case where I can't remember what it wasn't even unfortunate. Did I tell you about the story when I managed to first get my X-rays onto my iPad so then I could go out for a nice dinner with my wife? This is like 2009, and so she's kind of annoyed that I'm pulling out my iPad. I'm on call. And I'm like, sorry, I just got to look at this. And she's kind of super annoyed. I'm like, the alternative is that we got to go back to the hospital. I feel like, what if I should be like super impressed with the iPad? And then I'm looking at it. I'm like, what the hell's going on here? And from where she was sitting, she's like, what's that hand? And there was a legit human hand holding the dog down on top of all the ribs. And I was so close and I couldn't see that so obvious. And I was like, exactly right. You got to sit back, come back all the way, and then go into the middle as well.
I remember taking an X-ray and looking at it like stunned silence, going, that is the weirdest bone I've ever seen. It looks like a sinus. And I realized that was my head. I took an X-ray of my head as I was holding the dog down.
There's a few people getting congratulations for their. All right, sorry.
I love the chit-chat, but people are yet for X-rays, mate. Steve, I just sent you on email some images that Gerardo sent through. I've got no idea what they are.
I don't know what they are either, actually. Let's see what they look at. I'll make up a history.
One second. Is this a download link?
They're probably just images on an email.
Hubert. Yep. Okay. Yep. No worries. I'm actually going to load them up into Osiris too, just so I can get.
Now, sorry, somebody did send me some images on Instagram, and I'm just too stupid to get it off Instagram onto my computer. So next time, for next session, if anybody has any pictures for us, and there were some cool pictures, I'm sorry, I forget who sent them. Maybe email them to vetveldpodcast@gmail.com. Then I can.
If you've got like the DICOM download links, then I can load it up on that thing where I can draw. I don't think I can load these up together. I might be able to.
Mine will just be JPEGs.
Oh yeah, I can actually. I'm gonna put them in socks. It loads up as socks, but we can do that. Okay, boom, boom.
Otherwise, if you have cool ones on hand, Steve,
I can load them. I've managed to put it straight in. 1 second. Okay, boom. Okay. All right, that's them, eh? Okay, ignore all this stuff on the side.
More lungs.
More lungs.
Oh, lungs are tricky. Like lungs are harder than abdomen.
Prof. Gerberger, who you know, Steve, taught us lungs so well at uni. I was all over lungs for about 2 weeks around final exams. Then it's just everything just fell out my head. I suddenly just became really bad at looking at lungs. And I think it's probably the most common complaint. I had some people ask me in preparation for the session, "Can we do more lungs, please?" I say we should focus on that, but just because of that episode we did on abdomen rads, I actually think we should focus on abdo as well, because I think a lot of us miss out on what you can actually learn from a good abdominal rad. We get lazy with it.
Yeah, sure. Right. So obviously a cat. So one of the things that come up as an obvious cat feature is just how long and slender the ribs, the humeri, the vertebral bodies. They're just long and slender, and they just look like they're so well designed for hunting. There is an artifact that jumps up on every single view just to be aware of. There's this large artifact here, there's one over here, and there's one up here too. So I don't want to be jumping to any significance on these big, they almost look like a bullet hole of lucency, but I think that's just an artifact on whatever system this came from. Whoever did send this, I think this looks like it might be one of those CR plates. So I would just have a look at that that cassette to see if it's damaged or if it's been jumped on, or that. Correct me if I'm wrong. If this is a DR, then there's probably a few other reasons why there's a massive artifact on every single view. Right. So quickly going through the skeletal spine. This is obviously a little bit of an older cat, mineralized costochondral junction. Not quite old enough to have all that. There's a little bit of DJD there. So see how the glenoid humeral joint has a little bit of roughening to that humeral cavity. So just it probably is on the slightly older age. And otherwise, nothing jumping out. That's the microchip, just for that question before. See how metallic it is, and then covered by that glass. That's my favorite thing in the world right now. And otherwise, skeletally, here we have those two clavicles sitting there, and everything else looks fine. Cranial abdomen, really nice detail. So we have nice falciform fat highlighting the ventral margins of the pylorus and the liver. And do we see it anywhere else? We do. Really nice detail. Cats are absolutely perfect for imaging. Like they're the perfect species for ultrasound, MRI, scintigraphy, PET scan, everything. It's like, I think cats are probably the supreme being based on medical imaging.
I agree with ultrasound. They have so much easier ultrasound.
Or schnauzers. Schnauzers are great.
You can get them to sit still for x-rays and
that's what our FAC stands for, mate.
All right, so I'm pretty happy with the cranial abdomen. It's got great dorsal detail. The stomach, that pylorus here, it's kind of tiny compared to the fundus. That's the way it should be, and it's almost parallel with those ribs. So I'm not concerned with the cranial abdomen at all on any of the views. Make sure I'm not going to eat my words. Splenic head just coming across there. Fundus. duodenum's just poking up the side there and then starting to head down from there. And then also we have all this fecal matter, in this region here, which is just the transverse colon. Okay, so skeletal structures are finished. The cranial abdomen's unremarkable. And now we're looking at the thorax. So I'm going to zoom in slightly so everyone can see just the thorax. All right, now the first question is the thoracic boundary and the pleural margins. Is the lung heading all the way up to the margins? And I'm pretty sure on the VD, the dorsal ventral view, it is. So there's no retraction, and I don't see any retraction up here at all. Sometimes you see what looks like lung being pushed away from the dorsal aspect back here, and that is just the longest colli muscles coming across here, and so it just looks like there might be a little bit of retraction. Just don't be fooled by the cat longest colli muscles up there. And then we have really nice margins to the heart. Oh, get out of here, that stupid thing. And so at the same time, there's just a little bit of more opacity or superimposed over here, but I think it's mostly lung. I don't think we have anything causing effacement of the diaphragm down there. Like the diaphragm looks like it wants to continue down there. So I'm pretty happy that I don't see any retraction from either air or fluid. Now I'll have a look at the airways heading in. So I like to do pleural space and then airways heading in. I'll look at the airways, and then the airways bring me out to the parenchyma, do my assessment of the parenchyma, and then vessels back to the heart. So looking at the vessels, looking at the heart size, clock face analogy, then the rest of the mediastinal structures, starting with the mediastinal vasculature. That's kind of the way I work my way through.
Wait, go through it again, please.
Yeah, okay. So starting with thoracic boundaries, so skeletal structures, diaphragm margin, sort of rib cage, then the pleural margins, making sure I'm seeing lung all the way up to the inside of the ribs, making sure there's no retraction. Retraction's either going to be gas or soft tissue fluid, potentially fat too, but anyways, there's no retraction. After the pleural space, I'll do the airways. So follow the airways from the trachea through to the, actually, I'll just verbalize it now. Trachea heading down all the way to the carina. So the carina is really just that bullet hole that we see across the two principal bronchi. Just an interesting look. I mean, just look at, it's not uniform diameter. The trachea should be uniform diameter. So the thoracic trachea is normal, but I just get a sense that the tracheal diameter here is not normal. It's just a little bit more thin. And cats don't really have that variation from cervical to thoracic trachea. So right now, I would probably just say that there's slight narrowing of the cervical trachea, and there's a little bit of a sort of vesicular gas appearance, and I'm not sure if that's just superimposed trabecular pattern from the scapula and the humerus here. So I'll come back to that. Let's just have a look on these views. It's not so striking. It just is a little bit dilated inside and slightly compressed outside. So right now I'm thinking about that sort of dynamic pressures. So when a cat is under sort of respiratory effort, if you're under respiratory effort to open or to close, what you do to the trachea in the thoracic cavity is going to be very different from what happens to the trachea in the cervical space. So if you're struggling to breathe in, it's going to pull your thoracic trachea open, and it's going to collapse your cervical trachea because the external air pressure is going to do that, and vice versa. So in this case here, I suspect this is a struggling to breathe in cat already. I'm not going to jump to any conclusions other than that, just to say I think that's relevant, not just some weird variation. Now airways, let's head through. I think these are all fairly marked, obvious airways. Like this is an airway down here, and it's quite obvious. It's not super thick, but it's quite mineralized, but just around them, we have lots of mineralized airways everywhere. So I think this is probably more likely, and I don't see any like what Gerardo was talking about before. I don't see any of those big tubular structures or tortuous vessels. I think most of what we're seeing, oh, that's a good one, just down here. So we have this circle, nice donut. It's not super thick, but it's prominent. And we have this weird irregular one here. So I actually think this is just a massively diffuse bronchial pattern. It appears to be affecting absolutely everyone in all lung fields.
Can you?
Yeah, sorry, you want to ask what?
No, I think you're still getting to it. I was going to say, can you see your vasculature on this? But I think
yeah, I'll get to that in a second. But on all these views, so yeah, I'm seeing a little bit more prominent airways, and that's a good one there too as well. So this is a diffuse bronchial patterns characterized primarily of just increased opacity of the airways, but maybe slight thickening and irregular sort of shape. There's that one, was it over here? Yeah, like that one there. See how it kind of gets, let's zoom in even further. It just kind of gets wide there compared to here. It's a bit more narrow and then it's wide again. So like, I think this is just, it's strengthening this bronchial pattern as having a bit of bronchiectasis as well. So just uneven diameter to these airways. Okay, so press the wrong button there. Load up this view here. And this is, what do we have here? So right now I can't tell which lateral view I'm looking at. So if it's not labeled, and it probably is, I'm just gonna have a quick look at the vena cava. So the vena cava is on the right side of the body, and it's entering this structure here. It's not entering this part of the diaphragm, it's entering this one. So the right side of the body, right side is down. And if you think about a water balloon, it's going to be super wide on the ventral downside. So this is going to be a right lateral view. And I'll just zoom out to see if it's been labeled, right lateral view. So just sometimes they won't send you a right anything marked. And then in this case here, we should see the vena cava come across the body. It's not a lot, but I just think it does cross the body there, the diaphragm. So that proves to me that's a left lateral view. Going off on a little bit of tangent, but one of the things that's kind of striking as well is this very diffuse, oh, look at that. That's a nice, sorry, I'm going to do a nice airway in between that rib. And there's a couple others. But overall, I'm just noticing a little bit more, let's just draw here, a little bit more sort of opacity, fluffy opacity all throughout this region here. It's a little bit more sort of ill-defined, hazy, increased opacity compared to what we see here. Like all of this I could probably explain by predominantly that bronchial change, but I just have trouble really highlighting this region, a little bit there as well. That's vena cava. So I'm going to add another lung pattern. So in this case here, it's increased in opacity, but it's not yet causing effacement with the heart. I don't see effacement of the heart anywhere, so I don't think this is consolidated lung. So it's not alveolar, it's interstitial. So we have diffuse bronchial. We have patchy interstitial, which seems to be ventrally affecting left. And looks like both the cranial lung lobes, potentially the right middle as well. Just over here, we have a little bit more patchiness around that area as well. Okay, right now, what else do we have? There is a little bit, wow, I just noticed this now. What is going on there? I think we have lung coming down. And I think this is lung margin.
Is that stretching around the dome of the diaphragm or something? From
yeah, I think it's yeah, but then why would it not be opaque there too, though? Yeah, I'm wondering if this is a pocket of gas as well. Do I see it anywhere else? Is it down there a little bit? Or is that just that loop of lung there too? One of the next things that I'm noticing is a very flat appearance to that diaphragm. And normally cats, you shouldn't really have that sort of curving sort of appearance of the diaphragm, and almost there should be not much distance between heart and diaphragm at all. So I think this is a degree of overexpansion as well, which probably fits with what we were seeing in the trachea. And based on that,
I'll tell you that it was like a Siamese cat with a history of intermittent coughing.
Yeah.
Okay. If you flat diaphragm, if you say overexpansion, as in
it's trapping a lot of air in the lung, and the problem is getting rid of the air rather than breathing in. So everything starts to look a little bit more overexpanded. Okay. Before we jump to any of those conclusions, I'll just quickly look at the heart. Now, cats, the dyspneic cat that comes in is this a heart cat or is this a lung cat? And as soon as you go and put that cat on the echo table to look at its heart, then sometimes they like to die right away. So one of the techniques that we were developing in the States was how to CT a cat completely conscious in a little mousetrap. It's a little acrylic tube. And the cool thing was you could CT them and they would lie still when the table was moving, because it's that earthquake reflex where you kind of pause. And the cats, I was like, there's no way that cat is going to hold still for this. And sure enough, when the table's moving, they were so perfectly still. So anyways, we would just do quick lung and heart measurement to help ER work out what they need to direct their treatments towards. But the vertebral heart score on the cat is completely useless on the lateral view. So don't even try to do that, where we take the carina. We take the carina down to the apex. I'm gonna have to zoom in to see it there. I think it's coming across here. And then we head back out and we do perpendicular to that as wide as we can, heading across maybe that way. And then we measure it. This doesn't help us with cats because cats don't get it's eccentric hypertrophy, and they get that concentric hypertrophy. Everything starts to smash into the middle in that HCM cat. They do, however, get really big atriums. So we look for that sort of Valentine's shaped heart, which means the vertebral heart score on the DV view is far more valuable than the lateral. And so what you got to do is just find the carina, and it's roughly here. Try to find the long axis. That square is super annoying. Try to find the long axis of the heart. So I have it there, and then get a width. And this is a legitimate width measurement across. If that width is more than 4 centimeters, you have a big heart. Mm-hmm. Or if it's more than 4 vertebral bodies on the lateral view. So take that same 332 pixels. It's not calibrated. 1, 2, 3, 4.
Which one do you start? Sorry, from
on still the 4th thoracic vertebrae, and as long as this isn't more than 4, we should be all right. Boom. So we're fine. The heart is fine. This is predominantly a lung cat. Does that make sense, or was that too fast? Was saying with the vertebral heart score on the lateral views is useless in cats?
Do you ever use like I don't know, greater than 2.5
intercostal spaces?
Intercostal spaces on the, is that worthwhile or useful anymore?
That's definitely worthwhile for the subjective measurement where you can quickly just eyeball and going, yeah, it's more than 2.5 intercostal spaces. I'm kind of concerned about that. Yeah. Now I'm going to do a measurement to, baseline measurement. Just don't do the lateral vertebral heart score. This is called a modified Buchanan's vertebral heart score. And so just get long axis on the DV view and just one measurement, just the width as it goes across that. And as long as it's not less than, not more than 4 centimeters or 4 thoracic vertebral body lengths, then you should be fine.
Why did you get the long axis for if you didn't use it?
So I could get the perfect perpendicular width.
Like perpendicular.
Yeah. Because otherwise people would be going, I can make a pretty big heart, but it has to be perpendicular.
Gotcha.
In the chat, put A if you think Steve should be saying vertebral instead of vertebral. I have the most weird accent. So grew up Canadian, which is pretty much an American accent, and then went to school in Hong Kong, which they drilled into how wrong my accent was, and so taught me how to say some words properly. University here, and then residencies in the UK. So the way I say words is kind of, as you can tell, weird.
We did talk about duodenum or duodenum. Yeah. So supposedly they might be right, the Americans.
Real question, Eleanor. I actually asked the same thing. Just to recap, how do you tell that it's an interstitial pattern?
Oh, right. Yep. So first question I have is the lung opacity increased or decreased or normal? In this case, it's increased. We've already talked about the bronchial.
It's wider than it should be.
Yeah. Yep. Wider than it should be. So then we have to work out, is it alveolar or interstitial? And with that, I'm just going to look for effacement. I'm going to look for the vessels that are gone, the margins of the diaphragm or the margins of the heart, or things that I know are soft tissue. I'm going to look for those effacements, even the pulmonary vasculature. And if I can still see pulmonary vasculature and detail to, these structures, then I can't make it alveolar. The weird thing is that everything that's alveolar started off as interstitial. So you do have that merge, especially on severity. As it starts to get more and more severe, it's going to become alveolar. But at this stage here, I just don't see that effacement. So I'm going to say this is predominantly interstitial. And one other thing too is that interstitial pattern up here in this dorsal lung field. The coolest thing is it's a very simple rule, but can you see the aorta or not? And if you can't see the aorta, that's interstitial pattern. It's this weird thing that nobody quite understands why, but the fact that I can still see the aorta here means I'm not actually worried about interstitial disease up here. I'm not worried about interstitial disease up here. I'm more worried about it down here.
Does that apply with the chorda vena cava as well?
No, it's just the aorta. It's just the way it is there, and the little bit of lung. Like there's no other superposition except for the dorsal lung and aorta. And if you look at it, I'm just trying to think, I might have an interstitial case, but it's just the aorta is just gone. And it's like, whoa, that's weird.
Would it be the same with an alveolar pattern? If you had an alveolar?
Yeah, alveolar pattern, but then you've got, the whole, it's just white out everywhere sort of thing.
Yeah, gotcha.
But if you're just wondering, is this fat or is this just bad technique or I can't really tell, is it bronchial?
These are great X-rays. These are great X-rays, mate, because I took them. So yeah, so it's not.
I think these are textbook X-rays. So you're probably just using this for your next textbook, right?
Hey, so can I summarize that, Eleanor, the answer to Eleanor's question? So you're looking, is it too white or is it black enough? Yeah, the X-ray.
Is it increased opacity first?
Increased opacity, so that I could look at it and go, yeah, that's wider than it should be. But then I go and look for the margins of diaphragm, heart, vessels, and say, well, I can still see the margins, so there's no effacement, and because I can still see the margins, but it's increased, then I go to interstitial. Whereas if it was alveolar, you'd start seeing the outline of the heart and the outline of the diaphragm.
You can see the outline of the heart.
You wouldn't be able to see it because of that effacement.
If it was alveolar.
Yeah.
Thank you. That helps a lot. I don't know. I hope that helps. Please tell us if we need to explain it better.
All right. So now that we've looked at the heart, make sure that all the other vascular structures in the mediastinum, the esophagus, anything else that we might have missed that we could see, which we can't. Right. And so in this case, our summary is just two different diameters to the trachea, the cervical portion slightly narrow compared to the thoracic portion, flattening of the diaphragm, diffuse bronchial change, plus interstitial pattern, mostly ventrally. So in this case here, I would have to say this is an obstructive airway condition, most likely feline asthma. Could have a really chronic, nasty infectious bronchitis. But at this stage, that's kind of the telltale sign. How I explain the interstitial pattern below is probably secondary, either if it's an old cat and we might have some onset of fibrosis as well, age-related sort of fibrosis, or it's just chronic disease. Maybe it's had this for so long that it's starting to show a little bit more of a fibrotic change to it. Otherwise, you just have an acute interstitial pneumonia that might be a secondary complication to being an asthmatic cat as well. So that's my first sort of differential. My second, if I'm going to dive into squeezing out more, I can't really make it anything. I don't see anything else that would make me include. So just one of the other skills, or not skills, one of the other techniques that you can just remind yourself is that Dammit V or vitamin D. Do you guys whip out the Dammit V vitamin Ds when you guys are working up cases?
Mm-mm. Tell me more.
Did we not go through that in the abdomen one? All right. So if you're struggling for differentials, you can go through your Dammit V or your vitamin D. They're both the same thing, just how you remember it. So if we did Dammit V, the first thing I'm going to think of, is there a degenerative process that could give me all these changes? And we've already talked a little bit about feline asthma. That's kind of a degenerative inflammatory condition. No, that's inflammatory. Let's keep it separate. So it's not a degenerative. Can't think of something degenerative to give us all these changes. So that's off the list. Then A is kind of this weird one. It's anomalous. So congenital anomalous. That's how we fit A in there. There's nothing congenital in this, because why would a old cat be suddenly congenitally coughing? It just doesn't really fit. Metabolic, could you have a metabolic condition for the DAM part of it cause all of this? So a metabolic condition giving you increased airways and alveolar lung pattern, it'd be weird, but maybe there's some, I was just trying to think if there's some correlation with Addison's in dogs with bronchial changes. And no, I can't really get metabolic. Neoplasia, could we have a diffuse neoplasia affecting all the airways and the lung parenchyma and causing obstructive airway disease? That's possible. The only one that I can think of, it'd have to be infiltrative. So you're gonna have to have a round cell neoplasia, in which case lymphoma is the most likely off the list. But we didn't see any masses. We didn't see any thickening of the airways. We just saw this generalized, focal thickening of the airways. I mean, we just saw this generalized increase. So I still have trouble giving this neoplasia. And then damn it, the I part is this infectious, inflammatory, iatrogenic, idiopathic. I love idiopathic. It's like they don't give idiopathic conditions in humans. They just find out what it is. But we get a lot of idiopathic conditions. But no, I would say infectious bronchitis could easily give this appearance. It'd have to be pretty chronic. And then T, trauma. Can't see how traumatic injury, even with that diameter, like if you got some swelling of that cervical trachea, then why is it giving all this other change? I guess if we did have trauma to the cervical trachea and now you have obstruction there, you would have inverse direction in the thoracic trachea, and maybe this is hemorrhage, and he just has chronic airway mineralization. So trauma.
It got kicked on both sides of the chest, unfortunately.
So yeah, okay. So I would have trauma as my less likely differential. It's on the list, but we're going to lower it down. No, as in, I'm just what we do there is like, hey, this is most likely feline asthma. Yeah. But if there's something that's going to stump me, I want to make sure I've at least covered it. And so I'm going to say, hey, maybe he got choked in that cervical region and he's got a bit of pneumonia and he just happens to have feline asthma too. Like maybe there's something there that we can squeeze out. And then V, vascular. Is this a vascular condition? It's really hard to make this vascular unless it's just interstitial hemorrhage and everything else is unrelated. It's unlikely. So in any case, that's how I just cover my bases before I commit. And in this case, I'd be going down the feline asthma, obstructive airway disease, and that explains pretty much everything. So what was this case?
Oh, no, it was a Siamese cat. They presented with coughing.
And just send it home on anti-inflammatories and...
Oh, I gave it some Metaclav, Dex, something. No, no, it came in and it hit the crash bench. It was dyspneic, and because it was Siamese history of coughing, we gave it asthma puffer as well as some terbutaline and then some butorphanol, chucked it in. We have an ultrasound on the crash bench, so I checked its saturation ratio was normal, so I just chucked it in oxygen, and then once it settled down, then we went to X-ray, took the X-ray, and was like, oh my god, well here we go, it looks like exactly what you just described.
So it's kind of, I mean, it's really neat because obviously, like most of the students that at some stage in rounds we have a feline asthma, and when they're going through radiology, they've just been on medicine and they've got scopes in their mind. And like, I mean, in the terms of the GP, you'd see this and you're not going to go, I imagine like you guys are going to stabilize it and saying, you know, we think this is it, at least treat it symptomatically. But no, there's never a point where these are being scoped for, for cytology or anything like that, right? That's just not needed right now.
No. But so presumptive diagnosis was, given the history and exactly what you were describing, was feline bronchial disease of some kind, whatever they call it now. They always call it some kind of something different every 5 years.
Do you guys see a lot of smoking owners still, and with asthma that's sparked up from that?
No, I don't know. Have you, Hubert? No. And you guys in the chat, do you guys see that? I haven't seen it in ages. I've seen it with the house fire. I've seen it with the house fire. That was the house fire. So, but that's a perfect explanation. Because for me, the cranial lung fields, like, they look really interstitially. I can't explain why. They just look a bit more white than anything else. But that was a spectacular explanation of that X-ray. Thanks, man.
Okay, no worries.
Steve, you are smart. I mean, this is so cool. We should do this often, because I think it's repetition helps. Because part of me listens to you and goes, "Damn, hell, I don't think I'll ever be that good at looking at X-ray."
And your voice is nice too, as well. I don't know.
It's kind of, it's fun, but like, I have the luxury of sitting here with a beer and no pressures, and that's just not what happens in your guys' real life when you have this owner is probably in tears and all that sort of stuff. So I totally realize that nobody has the time to go through looking at vertebral bodies, looking at T3, 4, 5, 4, 5, 6, all that sort of stuff. But if you guys are going to send it somewhere, you want to make sure whoever you're sending that to have a look at while you're dealing with all your other 400 cases are looking at absolutely everything. And so the only thing that can help everybody is, and this is what we've talked a little bit in Hugh's podcast, is having a quickly accessible database of similar cases and normals. And it's almost unheard of outside of the referral world. But as soon as you save something, and if you get at least some confirmation, write that down, write that case, start building a database where you can quickly search these cases. And the other cool resource is radiology, vetradiology.net. I don't know if you guys have come across that. That's Alison Swingenberger's website out of UC Davis. And she posts probably 2 or 3 cases a week. And it's got the full history. It'll have cytology. It'll have histology with it as well. And you can search by, cat asthma or feline asthma or linear foreign body. And so from there, I think you can even download them. You might even be able to build up your own DICOM database or on your DICOM viewer with those cases specifically. And then you just search quick feline asthma. Let's just compare this. Oh yeah, the diaphragm's out there. Or even more value is just a normal feline 3-view thorax study. And I
was just thinking of that, what you said, Steve, because when you said, the diaphragm's flattened, once you point it out, I go, oh yeah, I can see it.
Yeah.
I may not have picked it up because I don't have that internal database, but having a normal feline X-ray there, you go, oh, this is quite a bit flatter. Yeah.
I'm just gonna see if I've got a
posted on to vetradiology.net in the chat, Steve. Maybe just check that.
Is that link working? Or sometimes I'm not sure if it's veterinary radiology.net or vetradiology.net.
Okay.
Yeah. Okay.
We can see the pictures of X-ray. So I reckon.
I'm just looking for. Oh, here we go. We got. Why is this cat?
So while Steve's doing this, while he's talking to himself, everybody put in the comments one thing that you've learned. I've learned a lot. I'd love to know one thing that's new or that you go, oh shit, that's really nice. Do us a favor, please.
Here I do have one. I'm just going to load this view up. So see how now it's got a far more curving line there, and you get this touch between the heart and the diaphragm, and you still get a bit of a triangle between there, but it's far more curving.
Put the other one up again.
Yep, 1 second.
Please.
Is that socks? I think I put it in socks.
Is that a linear for everybody? What's that one?
Ooh. Yeah.
Too late.
Let's not start this. Here we go.
All right. So if we just zoom into the diaphragm there, it's probably not going to be as obvious, but just there's a bit more separation. And I just find, like, if I put a straight line on this guy, it's kind of coming in a little bit.
Yeah.
So it's not super obvious. I just get the sense that it's not perfect. Yeah. And also this is an abdomen view. So we're coming off it at the side. This might not be a perfect one to compare. Oh, it's a great x-ray. Where did this come from? Usually I get to the end of the day and I think, oh, I don't have any x-rays to report. And then my buddy from Chicago will say, hey man, can you look at this? Tell me if it's cancer. Okay. I hope everybody we've muted, I hope it's not just been me talking gibberish for a while.
We started with 29 people. We still have 27. So you did it right, mate, for an hour and a half.
And again, this was like the first of hopefully many, but also only if it works in this medium. I think Zoom makes it a little bit easier, but if there are cases that you guys want to do, you can send them ahead of time, and then at least we have those to chat about.
We'll get some feedback from people, please, on Instagram. Let me know in the DMs where you've been messaging us. Did you like it? What else would you like to see? Would you like more? And we will say every 2 weeks, maybe every week is a bit, or even once a month. We'll see. Let's aim for every 2 weeks. I'll let people know. Let us know if you like the time as well. I try to pick a time that works for sort of UK time in the morning and then Australia in the evening, hopefully after work for most Aussies. If you're still at work at 6 o'clock in WA.
The Monday was a bit of a struggle. I was just going to show you a CT, only for me because I forgot my kid's swimming lesson, so I'm in a bit of shit. I was just going to show you. This is a CT of a cat thorax. So CT. Sorry, here. Can we keep going?
Yeah. People are welcome to leave. Don't feel that you have to be polite and stay. If you need to get somewhere, drop out. But if you're loving it, stay on board.
So this is just a cross-sectional view of a cat thorax, and in in X-ray, we deal with 5 opacities, and you can only really see the difference between 5 opacities and how they interact and how they touch and how they efface and how they provide contrast. CT has the ability to see 4,000 different shades. And our eyes cannot possibly comprehend that level of detail. So the CT says, all right, stupid human, I'm going to break this down for you very easily. Here's a bone window, just look at bone. And here is a lung window, just look at lung. Don't look at anything else. And here's a soft tissue one, but it's really granular because I didn't acquire it in that sort of condition. But it's super good because in lung window, all we're looking at is lung. And in bone window, all we're looking at is bone. And in this case here, just wanted to show you just how nicely, if you remember that DV view, that vein is going to be central compared to the artery, which is going to be on the outside. And on the lateral view, if I just redo this one, can I do that? I can. And then make it MIP. Sorry, I'm just doing a quick little. So you have the vein is ventral now too. So that's just all from that 3-dimensional appearance of it. But yeah, I think just wanted to show something extra as well. This is mostly an abdominal study, but at least just CT is just beautiful for the lung. It's freaking beautiful. Do we have any aspiring radiology type people in the group? Just gonna say this: you can work from home. And there's lots of people looking for radiologists, and you get to sit on the fence all day. Taryn, actually, Taryn,
it could be 1, 2, or 3.
Yeah, sorry.
and if you can't tell, it's because the image quality was terrible.
Yeah. Sorry, I can't work under these conditions. Yeah.
Hear my sound effects. I should have been using my sound effects. Can you hear this? Wait.
No, I can't hear. Right?
Can anybody hear that? No. Oh, never mind. Bugger.
Any questions either on any of those cases that we saw or anything that's keeping you up at night? If there are. I remember during my residency, I'd start dreaming about X-rays. Not because I loved them. It's just that you see them all the time. And, you know, when you work long hours, you just start dreaming about cases. Sometimes I wake up and I feel like I have an exam in like 2 hours.
Yeah.
Like not a vet school exam, but like a high school exam. And I'm freaking out.
I've passed those nightmares about 5 years ago when I finished all my exams. But I don't know if there's something you can do on lungs. Maybe we'll prepare this for later. The common things that are misdiagnosed or something, you know, like, I don't know. Are there things you see in chest rads where you're like, this is potentially what it is, but it's not what it is, and it's normal? I don't know.
Oh, actually, I had that one. I had one today.
Next time it's getting late.
Okay, sorry.
That's a good one. If you have any rants, stuff that you see people do that make you crazy, then let's think about that as well. Okay.
I'm going to submit some really super rotated, overexposed radiographs for you, mate, and yeah.
Okay, guys, I put a link.
I'll imagine it.
I put a link to Steve's startup to VetDB. It's a really cool thing. Go check it out for your practice, or tell your bosses about it. Thank you, Steve. Let's land this plane, guys. Thank you for joining us, and we'll let you know when and where next time. I love that. Good night.
Thank you.
See you guys.
See you guys.
Bye.
Bye.